Thanks, and hello to everybody. I want to tell you that I have given this particular talk many times in all sorts of, like by webinar or in person, but never via this Zoom. So if you see me just staring stupidly at my own face, that's because I'm not used to that. So this is the first in a currently scheduled set of 3, and this is really a basic talk about quality improvement. I need to tell you what Qualis Health is. Has anyone heard of us before? Raise hands. No. Okay. Qualis Health is a private not-for-profit company headquartered in Seattle, but we have offices around the United States. We do a lot of utilization and case management for state Medicaid agencies. That's why we're in all sorts of state capitals. But the side of the company I work on is quality and safety initiatives, and under that we do person-centered medical home or physician practice transformation activities, health information technology projects. We support Medicaid agencies for their external quality review, but the hat I wear most often is working with the Quality Innovation Network Quality Improvement Organization contracts, that is Medicare, for the states of Washington and Idaho. So we do a lot of work for our Medicare beneficiaries, which has led me into the geriatric realm many a time. So let's just cut to the chase and say, what are we here talking about today? Well, what's a quality improvement project? Well, you can see that if these people were wallpapering, they'd probably be fighting, but they're painting. So they're improving the quality of their room. And basically, there's a whole bunch of different definitions of QI projects, and they're all very boring. There's a very lengthy one from the ISO. But basically, it's any activity that improves an aspect of the quality of delivery of the service that you're providing, either quality as experienced by your organization itself or by your customers. So you can improve things that make things better for you in your daily work. You can improve things that help out your customers or patients. Can healthcare conduct quality improvement projects? Well, of course we can. And it can get really bewildering to kind of think about, well, what are we going to do? How are we going to scope our project? A helpful way that you might want to start thinking about categorizing projects that you want to improve would be to think of the 3-part or the triple aim. Has anyone heard of the 3-part aim, triple aim? Okay. This was a theory that was developed by Dr. Don Berwick and John Whittington, both of the Institute for Healthcare Improvement, probably between 5 and 10 years ago, where they theorized that our healthcare system could work at its optimal best, basically, if we maximize performance in 3 different areas of the system. And this triple aim has since become the National Health Quality Strategy, in part because Dr. Berwick was the interim administrator of CMS for 18 months and is the CMS, or Centers for Medicare Medicaid Services strategy as well. The 3 areas that you could use to kind of categorize your projects then, which will line up with this national quality aim, is improving the patient's actual experience of care. And a lot of people, when they think about experience of care, they think about satisfaction, like, did you like the food? Was my room always clean and quiet? But it's also the care that is given to individual patients themselves. Did they get the care that they needed, and only the care that they needed, at the right time, when they wanted it, in the right setting? So that's individual patient care. Did this particular patient who has diabetes that I'm looking at right now have all the preventive services that he or she needed? You can also think about projects related to population health or the health of larger groups. That usually focuses on using data to identify populations of people. So it could be the population of people in your clinic that you know have a diagnosis of hypertension. It could be the group of people in your clinic who are over age 65. It could be your 2 and under children. And you're thinking about that group not as each little individual, but of all of our folks that are over age 65, what % of those people have received all of the recommended immunizations? Are they fully immunized? Do they have an annual flu shot? Have they had pneumococcal vaccine? Have they had a shingles vaccine? Something like that. That gives you an idea more of the group of people and how you're monitoring them for that. And the third category of projects might be to reduce costs of the healthcare system through quality improvement. We know that in the United States we pay more per capita for healthcare than any other nation, and our outcomes are relatively poor, especially related to the amount of money we spend. So we know there's ways to help make our systems more efficient and more effective at the same time. So the triple aim gives us just a little bit of a way to maybe categorize. I would guess that most of the projects you're going to do for this activity will probably be around the patient experience, so as specific services delivered kind of on an individual basis. But go ahead and think of population health projects. Think about efficiency and reducing costs or improvement. Those are good topics as well. So all healthcare settings can and do conduct quality improvement projects. They are done in hospitals, they're done in primary care practices, specialty practices, home health agencies, skilled nursing. People can conduct quality improvement projects on their own health at home. Everybody can do it, so it's not scary. It can be jargony, but it's not scary. So within the context of this work under the Geriatric Workforce Enhancement Center, my piece of this, the part I'm collaborating with the rest of the team, I think it's kind of two parts. One is we want overall, of course, to improve aspects of care for older adults. The population of those older adults and each individual's care as they come in, but also to build improvement capability within all of the residents, students, and other trainees that are participating in the various sites. So that's really what I'm here to talk to you about today, is that second piece. Is that wherever you go, because you're likely not going to be in the setting you're in right now for the entire rest of your professional life, but wherever you go, you will have the capability to lead projects and do quality improvement throughout your career. That's the idea. What is the idea? The main idea here is just to make something better. And although you're going to hear some things that you might think of as a little bit kind of jargony, I'll try to explain them, but the main idea is just to think of something you wish were better. And let's focus mostly on kind of the care for the geriatric population in your clinic right now. Does anyone have an idea that you've been thinking of that you would like to work on as your QI project? Any proposed ideas? So I can see you. It's okay if you haven't thought of anything yet, but do some thinking in the back of your mind, because we're going to get... Right. And maybe I can explain a little bit that the quality improvement for the geriatric population is kind of split into two groups under this project. There's a few clinics each year that are going to get more intensive hands-on support with their projects, but everyone else, you're certainly free and encouraged to think of projects that you could do in your own clinic. I'll give you an idea that we know is going to be worked on by one of our clinics, and that is they're a little bit concerned because they have a substantial population of folks in their clinic that have dementia. And people that have dementia often express behaviors that some people might find disturbing or unsettling and might bother the patient themselves. And in order to control those behaviors, sometimes those folks are put on psychotropic medications, which have pretty severe contraindications for them in these populations and aren't necessarily evidence-based. So that clinic is working. They feel like maybe they're using too many psychotropic medications and they want to reduce that. That's a perfectly good project idea. But once you get your idea about something you want to improve in your clinic, you can think of anything. It could be pediatric or whatever you're thinking of. The very first thing you need to do is to realize that in healthcare settings, quality improvement is a team effort. It is not the job of the quality improvement manager. Nobody knows where their office is anyway. It's not the job of just the one physician that kind of gets an idea and they want to do some research. But to really improve it, you have to have a team. So take a look at these people here in the picture. Is this a group of people or is it a team? Anybody can answer. Okay. Well, you probably all believe, who thinks it's a team? Let's just do that way, so you don't have to speak. Everybody thinks it's a team, right. So I'm going to ask you some more questions, but I can also just keep talking. What makes it a team? Pardon? Why do you think they're a team? Are we muted? Okay. Well, for the sake of time, I'll explain why it's a team, but these are things you're already noticing and probably thinking. For one thing, they have different roles. You can tell the person that's closest to us there in the yellow jacket clearly has a different role. That's the person that sets the stroke rate. They have things that they need to do that's different. In fact, each person in each different seat have their own specific roles. They also have a goal. They have a shared goal. They're not going to row and row and row and row and row until they die of exhaustion. They're going to row a certain number of yards and they're going to stop. So they have a goal. They not only have a goal, they have a measure that can tell them something about their performance in moving toward that goal, right? They're going to know how fast they went. And they're also going to kind of have an idea of kind of parameters around how fast they want to go. They want to go faster than yesterday or whatever. So they have a goal, they have some metrics, they have rules, and they actually also have shared processes. Because if every person in that boat was just sort of flailing in their own particular way, they wouldn't go anywhere. So they have some shared understanding of the methods of getting there. Quality improvement is exactly the same way. You need representatives of the different roles that touch whatever you're trying to improve. Let's say it's immunizations, to be able to really improve it. If you're thinking of immunization project, you'd probably want front desk staff because they collect some of that information. You'd want your medical assistants or people who put data into computers. You want providers. You may want pharmacists. You may even want the people who hand people their after visit summary to help figure out a process like that. So once you have your team, now you've got to get them all to speak the same language. So if you look at the little characters there in the lower left, they're all speaking, they're communicating, but they don't understand each other at all. And what we like to do at Qualis Health anyway, and you can see the little folks there in the Qualis Health sweatshirts, we all speak the language that we call model for improvement. And whenever we're talking about improvement. There are many different types of improvement methodologies. Does any of your clinics, do any of you use like lean for quality improvement? You do, lean. Anybody use Six Sigma? I know the Providence clinics and hospitals have invested heavily in Six Sigma training. That's fine. The point is to really have a language for quality improvement so that when you're talking to each other about what you're going to do, that you're kind of using the same jargon and same words. And I have to say that I believe, and at Qualis we believe, that model for improvement and plan, do, study, act cycles are actually foundational to the other ones as well. Because you can't really do a lean project without being able to do small tests of change, et cetera. So we're going to learn about the model for improvement. Now that sounds super boring and complicated. Whenever anybody says model, I'm like, I am done. But the model for improvement is 3 questions. And it just helps guide your project and how you think about improving. First of all, you have to think to yourself, what are we trying to accomplish? How will we know what changes in improvement, and what changes can we make that will result in that improvement? Those are the 3 questions of the whole model. See, now you already know that. I'm going to go through them one at a time. So think again, and you don't have to think of a geriatric subject if you don't want to. Maybe something in your own life or something around the care in the clinic site where you currently are. What's keeping you up at night? What are you worried about the care? That's going to be something that guides that first question, what are you trying to accomplish? What's keeping us up at night? What's keeping Dr. Ting's clinic up at night? Is it they're afraid that their dementia patients may be on too many psychotropic drugs? That's bothering them. So what are we trying to accomplish? What's keeping us up at night? What's the problem? It's all well and good to kind of say, well, we sure have a problem, and we're going to make it better. But that's not a very specific aim. And if you think back to the people in the boat they're rowing, they kind of know when they're going to stop, and they know how fast they're going to go. So I would encourage you to write an aim statement. So getting a piece of paper and write down what it is you're trying to accomplish. It will help you, if you ever get lost along the way in your project, to be able to go back and revisit what you wrote. Because a lot of times people start out trying to do thing A and they find out, oh my goodness, we went to B somehow. To pull that back out and look at it and say, oh, yeah, we did change what we were trying to do, but that's fine. We really mean to do this other thing, or oh, we need to fall back and regroup because we really wanted to do this psychotropic drug thing and we kind of forgot to do that. So I would say write it down. And so state it very clearly. Use numerical goals. You don't say we want to make it a little bit better eventually, because then you'll never know what happened. And state kind of the time frame and what you're going to try and do. So for example, by the end of 2017, we will reduce the percentage of our dementia patients on antipsychotic medications by 30% through medication management and implementation of behavioral interventions. I think that's a good aim statement. It's going to ask you to write one. So any of you that have a piece of paper sitting in front of you, something you can write down, it would be great if we take like 30 seconds and have you just write down an example of an aim statement. Let me go back to the one before. And write something down, and then I want at least one person to read me an aim statement. Read about any topic you want. It can even be a personal thing. Give you a few more seconds. I know it can be hard to think up something. Does anyone have something written down yet? I see writing taking place, so. Okay. There at the Puyallup site, would you like to tell me what you wrote? Oh, we can't hear her. Are you muted? Oh, sorry about that. So while she's doing that, does anybody else have something they want to read? Heard something for a second.
Are you guys able to hear me?
Yes.
Oh. Hi, it's Amanda. I'm a fellow at University of Washington.
Hi.
Hi. So I used yours as a structure, but I said by the end of the year, we will decrease our no-show rate in clinic by 10% by implementing a call reminder.
Very nice. Does anyone have feedback for that clinic on that aim statement? I thought that was great, and I'm actually, oh, do we have another one? No? Okay, well okay, Skagit? No, that's a really good one, and I do, that's a really good example of kind of a workflow issue rather than an individual patient care issue, which is a great thing to work on. And in fact, I was out at a clinic trying to do that just a week or so ago, so it's great to hear that. Perfect aim statement. Nice, clean, crisp. Everybody knows what it is. So now you've done the first 1/3 of the whole model for improvement. You've written your aim statement. The model for improvement, what are we trying to accomplish? Now we're going to go to one I'm taking a little extra time to talk about, and that's how will we know a change is an improvement? Let's say you make a change in something. She goes and she implements a call center. How is she going to know that things got better? Well, you have to measure it, and this is the part of quality improvement that makes most people kind of crazy because no one wants to measure anything. But that's part of the model for improvement. We have to come up with some measurements. The good news about it is that it's just measurement for quality improvement. So in general, there's 3 kind of big buckets of measurement. One is measuring for research, and you're probably all super familiar with that, where you're trying to test if some sort of a treatment is better than nothing or better than some other type of a treatment. And for that sort of a thing, you have to have very large sample sizes, you have to have certain randomizations and blinding, you have to be able to figure out statistical significance, kappas, all that sort of thing. Yay! Quality improvement is not measurement for research. Quality improvement is not measuring for accountability either. How many have seen like UDS measures, HEDIS measures, CMS, hospital compare, any of those things? UDS is the measure set that is normally often reported by federally qualified health centers. You can go out on websites called the Compare Hospital, Nursing Home, Home Health Compare. Those are websites where CMS is attempting to hold providers accountable for the care they deliver by collecting data in exactly the same way from facility to facility. So everyone follows the same technical specification, the same exclusions and suppression criteria are applied to those measures. So what you can say about accountability is that if I see Clinic A's mammography rate is 85% and Clinic B's is 50%, I'm pretty sure there's actually a difference between those 2 clinics. That's measurement for accountability. Yay, we don't have to do that for QI either, because you're not trying to necessarily hold your clinic accountable when compared to everybody else. What you're trying to do is hold your own clinic or practice or your own individual actions compared to yourself. Is it getting better? That's measurement for quality improvement. So it's just enough to help you say, yeah, you know what? I think in our clinic when we implemented that call center and we've let it run for about a week, that not only no one has quit, but they seem to be handling the call volume okay, and so far so good. We're not quite sure yet about the no-show rate, but we're kind of in the so far so good category. So you have to have some metrics. You have to set them up ahead of time. I want to say a couple things about how residents, fellows, students, and others that may be only attached to a kind of a longitudinal project in little portions of it could definitely help out with this project in such a way that you will, satisfy the requirement that you have worked on a quality project. One of the things is to help set up the set of measures. You could also help to write that aim statement. We can back way up to aim statement and just say, you've got a project you want to do in your clinic, but you don't really know what a benchmark is. Because I know they set a goal there. This was a draft aim statement. I know about the no-show rate. But what could you know about what is a national or local regional standard for no-show rates in a clinic of your size? The students, residents, fellows, et cetera, could do some of that research on that and help you develop what the benchmark could be and write a good aim statement. Included in the aim statement also, of course, is kind of the general approaches you're going to use, and maybe you don't know what those are. That could be another thing you could do, is to research that and come up with a plausible plan. Same thing with the set of metrics. Now we've got our plan, now somebody needs to develop a set of good metrics. In general, in quality improvement, you can only improve as often as you measure. Many places rely on external organizations to send them data, and that happens about quarterly. And that means your QI project is going to take a very long time if you're only measuring quarterly. So ideally, for quality improvement, because again, we only want that information that allows us to kind of have the feeling we're heading in the right direction, at least in the beginning, we want to make measurement into our daily routine. Like maybe you start with your call center and you have the no-show rate, and at the end of the day, either they're doing it on paper scheduling or they're doing it in their computer, but they could just tot up all the slots, and it could get really bewildering to do all the slots for all the providers, but maybe just for one provider, no-shows. Write it down on a little piece of paper. Monday, 5 no-shows. Tuesday, how many? Because that's not scary, and it's something you can collect every day. So you want to plot them and put them where all that team that's working on it can see it, so that they can continue to feel really involved in it and can kind of look and think about what the data look like. Again, quarterly is not often enough. We also like a little family of measures. Can I put that down here? No. A lot of times in healthcare, we like to think only about outcomes, and we don't measure really how we're doing on the processes that lead to the outcomes. It's like, gee, we would just really love to have fewer people on psychotropic medicines, but how are we going to get them there? So what do we need to measure about what we're actually changing in order to get there? You do want an outcome metric. So the no-show rate in and of itself is her outcome metric. For our clinic that's working on the dementia project, antipsychotic use rate is definitely one, but they could come up with others. Falls, hospitalizations, things like that could be associated with it. So they could have some outcome measures, but then they're going to measure some process things. In my little fake AIM statement, I put medication management and behavioral interventions. So they could have as a process measure, oh, I'll get to that in the next slide. Never mind. I just realized, I remembered I have a slide on that. And then as another part of our little family, outcome process, and then what we call balancing measures. Has anyone ever heard of a balancing metric? People forget to do this. It's really looking for the unintended consequences of what you're trying to change. You're asking people to change their work processes. You may be asking them to do things that take extra time. You may be doing things to the patients that you think is really great, but boy, they sure hate it. So often balancing measures are patient or family satisfaction, but they could also be, you know, if you're changing medication regimens or whatever, you know, people that don't tolerate the new routine, et cetera. So you want to have all those things. So let's think about our sample geriatric care project. The outcome measure is % of dementia patients on antipsychotics. How about for processes? Number of dementia patients who have had a medication reconciliation done. Just to make sure that their medications are approved for people in the geriatric age group. Looking to see if they have any of the high-risk drugs there, including psychotropics. How about the patients that are in your post-acute settings, say in your nursing homes or within the clinic, that you trial on tapering them? You may have patients in your clinic that have been on the same dose of psychotropic for years and years and years, and nobody's tried to get them off of it. So maybe try tapering that. How about the number or percent, you can do either one, of patients and caregivers who have been educated about non-pharmacological ways to reduce behaviors in dementia? There's all sorts of different types of behavioral training that could be accomplished. So you can count that. And then maybe balancing patient and family satisfaction. You may have that person who's been on the psychotropic med for years and years, and you start to try and taper them, and they perceive that the behaviors are increasing and they're not very happy with it, or they're nervous about taking their relative off of the med. Just keeping track of that is important, because you don't want to go way over to improvement and yet have a lot of people unhappy at the same time. So you're going to make up a list of measures. Oh, there's provider satisfaction. Yeah, the provider's like, I don't have time to teach them how to do behavioral interventions. This is ridiculous. I have 15 minutes. That's something you need to track. All right. Okay, so coming up with a list of metrics. That could easily be something that would be a key part of the QI project that the people that kind of cycle in and out of the clinic could help with. So how do we display this data? Have you ever seen quality improvement data or other data in a bar charts? Bars, pies, stuff like that. Don't use those for quality improvement. Oftentimes you'll say, like, well, here's, you know, Clinic A, quarter 2, 2016 versus national on some diabetic measure. Like, well, that shows us where we were at one point in time. It doesn't show you if you're improving or not. And it can be difficult to see a lot of different bars, especially if they're meant to compare versus some benchmark or other, all arrayed on the same graph, and you don't know. Run charts, line graphs. It allows you to see over time. This is a fake. It has a goal of 98%. I don't know whoever gets there, but here is a run chart. Qualis Health has a run chart tool on our website that you can, it's under the, I think it's called qhmedicare.org, that you can download. You just fill in a little Excel spreadsheet and it'll populate your tool for you. We call them annotated run charts because you just make a little note on every every dot that you put. And just after I said don't do things quarterly, my example says quarterly, but you can ignore that. So this is an example. We went and we decided we're going to educate the families about how to intervene behaviorally instead of giving their dementia patients drugs. And we're going to educate the families how to do that. So at the beginning, only about 25%. We go around and we ask our providers kind of how many of the families are you educating. It's not too many. So what we decided to do was we're going to educate everyone. This is how to do the behavioral counseling. Here are some resources. Here are some websites. This is how to do it. And we noticed that things are going up a little bit, going up to about 40%, but we're thinking people are forgetting to do it. So we're just going to use sticky note, kind of taped up pieces of paper. Seeing a dementia patient today, think about, scrolling to this page in your EHR or whatever, because you're going to have a set of resources. That seems to go pretty well. So in our little pilot pod of providers, we're going to say, what if we bribe our IT people to create a little EMR queue for them, and we're going to see if that works before we spread it to everybody. So if a patient over age 65 comes in, maybe there'll be a little reminder that says, how do you, does this person have any signs or symptoms of dementia? Maybe you want to try doing this. We think that's going to be a home run. We love it. And then we look there at Q4, and we find that our rate has dropped. And we're like, why? Well, it turns out that's Q4. Of course, it's flu season. Nobody does anything for QI during flu season. We all just run around and deal with flu. But that's okay. It's okay. Because at least we know what it was, and then we have some miraculous success on the rest of the chart. It's just meant to be an example of this is how you can track if things are getting better or worse. And if you annotate it, then you can at least tell yourself what was happening at the time. You can do this with graph paper. You should do it with graph paper. Places that I've been, I don't know if any of you have been in a group health site before, but where they have their lean sites, they have a room that's absolutely full of charts and things, and many of them are handwritten on a little piece of paper. Kittitas Valley Community Hospital also does this. They have a whole wall of a room that's mostly things that people are tracking with pens and paper. You can get way too interested in technology and forget to do QI. So now you've done question 1 and 2. What are we trying to accomplish? How are we going to know if it's an improvement? You're going to write a name statement, you're going to measure it. The third thing is, we want to improve it, we just don't know what to even try. The good news is that for many of the aspects of care around individual care for patients and populations, there's lots of resources already out there from CMS, from the Institute for Healthcare Improvement, from HRSA, from AHRQ, from the various specialty societies that you can just look up and try and pull some good ideas out of them. There's toolkits aplenty. There are also toolkits for the workflow type things about no-shows. Safety Net Medical Home Initiative Implementation Guide on Enhanced Access is out there. That's a good one to try. So there are things out there. And again, this is another way that I feel like the residents, fellows, students that go through the clinic and aren't going to be there for the whole life of the project could really help set up the project well, is to come up with a robust set of changes that you want to try in your clinic as part of the QI project. But another thing is thinking about that team of people you're going to put together to do your project. Like, who knows how to improve work processes? Is it a manager or a medical director or the CEO of the clinic? No, it's the people that do the work, right? So if you're going to do something around, immunizations, how come such a low % of our older people are fully immunized? Start asking the people that do the immunization work. Start asking the medical assistants who take the history, the people that offer the immunizations. You ask them, what do you think could help? And they will have a million ideas, and it's okay because this is brainstorming and you get a whole lot of good ideas. So that is the entire model for improvement. You should have a list of changes that you think are going to make things better. You have your aim statement, you have your little set of metrics, and you're good to go. Anybody have a particular question right now? I know I'm going fast. Okay. Who has done Plan, Do, Study, Act, or Plan, Do, Check, Act cycles for anything? Yay! Some of us have. You can do these in your own personal life. You can do them all the time. This is what makes that model for improvement come to life. It makes you get up and start doing something. So this is the Plan, Do, Study, Act. Some people say Plan, Do, Check, Act cycle. It was actually developed by a guy named William Edwards Deming back in kind of the post-World War II era. He was an improver. He's a leader in improvement science, and he went around to American industries because he thought they could do things better. He thought they could build better products and they could do their work better, and they said, no thanks, we don't want you. So he went to Japan. And in Japan, he teamed up with a guy called Taiichi Ohno, and they came up with the Toyota production system. And this is kind of one of those things that came out of that. I'm kind of glomming together a lot of QI stuff, but that's where it came from. And it really is true that the Plan, Do, Study, Act cycle allows you to do rapid cycle, small scale tests of change. If quality improvement projects are often done completely wrong, in which a bunch of managers run off to an office somewhere and they sit in there for about 6 months and they come out with a giant book or toolkit of something and they go, here, do that. Nothing ever gets done, and pretty soon it's a doorstop and then it's all being ripped out and thrown in the recycling. The Plan, Do, Study, Act cycle allows you to test things quickly. You can do a Plan, Do, Study, Act cycle today in 22 minutes when we're done on the next thing you want to improve yourself, because you're going to do it very, very small and very quickly. One person, one time, just test it. But do the steps in order. Plan, do, study, and act. Most people, if they don't do them in order, all they do is plan, 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 and you never do anything. So I'm going to walk through this, and I'm going to do a personal life version of it. So let's say I am interested in becoming more physically fit, and I want to lose 15 pounds. Everybody wants to do that. We're going to lose 15 pounds by July because that's when we're going to Hawaii. So my plan is I'm going to change something, and I'm going to test it, and I have a prediction. So plan and prediction both start with P, so you can remember that. And I predict that if I set my alarm for 30 minutes before I usually get up in the morning, I'm going to be able to get up and go for a walk or a jog, and I can do that. That's my entire prediction. I'm going to be able to do it because I want to get 30 minutes of exercise in my day. Because I believe that that's a change that will lead to the improvement I want, which is the 15 pounds. So I predict that I'm going to do that, and then I do it. I set my alarm, go to sleep, alarm goes off, I get up, I'm ready to go, and there's the dog. And the dog wants to get fed. Like, oh, okay, the dog gets fed. Then I'm going to slap the dog food in the bowl, put that down. I'm like, oh, I have to set up my coffee maker, and I have to put the coffee maker on. And then I get out the door. I'm a little bit late, but it's all good. And I'm walking or jogging along, and I come to a cross street, and there's a school, and there's all sorts of buses and cars and crossing guards, and impossible to get across the street. And it takes me quite a bit of time to negotiate that. And I finish my walk and my jog. And so during my doing of this, I'm kind of collecting this information. There was a dog, there was a coffee pot, there was a school. And I come back to my house and I'm 10 minutes late, and now I have to basically go to work with my hair in a ponytail, and I kind of have a bad day the whole day because I was late. So I've planned it and I've done it, and during the doing I'm collecting data. Now I study it. What did I learn from the information I got? Well, what I learned was that there were some unexpected things that got in my way, and it made me late. And what I can do under ACT, there's only 3 choices, and handily I'll start with A. I can adopt my change because I loved it. I can adapt it. I can change it a little bit, or I can abandon it. And there's not much risk in my doing any of those 3, right? Because all I've done is be a little late for work one day. So what should I do? Should I adopt, adapt, or abandon? So for this test, I should adapt it. I should change it, right? It wasn't impossible. I was able to do the walk. I was just late. So there's a whole bunch of different options for me to adapt it the next day. One thing I could do is like set up the dog food and the coffee pot the night before. Put the dog food, a little plastic over it, and just be ready, have the coffee pot maybe on a timer. I could the next day instead just change my route to avoid the school. I could just do something slightly different. If I decide those are just obstacles that can never change, I can just decide I need to set my clock for 10 minutes even earlier in the morning if I want to do that. And then I do it again, and I see if it gets better. In the clinic setting, you're rarely working all by yourself, so you may be asking somebody else to change something that they do. For example, in an immunization project in a clinic, you might be saying, gosh, we're pretty sure our elderly population's not getting flu shots. What we're going to do is we're going to ask the medical assistant to see if it's possible for them to document immunization status as part of their rooming process, because they don't already do this. We're going to ask Joe because he's the friendliest MA and he always says yes no matter how stressful the day. Always says yes. So Joe goes in there and he does it. And as he does it, he's kind of collecting how it is to do it. And actually he noticed that it was out of his general order to do this process. That collecting that data, he had to flip through some other screens, then he had to tab back to get to the other screen he wanted, and it kind of got him off his rhythm, but he was able to do it. I catch him as he's coming outside of that room, and I say, so how was it? He tells me. We're like, okay, and we study what that was about. And then we decide to adopt, adapt, or abandon. He could do it, but what we're going to do now is to make a little change in how he's going to do it. He's going to go through his regular workflow, but be able to access the screen when he needs to access it and then ask. Like what he did was pull up the immunization screen the first time. Now we're just going to go through his regular workflow. Try it again. So you're usually working with other people as a team. But there's not much, you can see there's not much risk, and this is why you're doing things fast. And this is why I think you all can do a plan, do, study, act cycle this afternoon. I bet you can. So now in your mind, think of the meanest, most obnoxious provider or nurse or MA in your clinic to work with. And now forget them, because that's not who's going to help you do plan, do, study, act cycles. It's the most willing person. If you really want to learn if something works, it has to be done with willing participants in the first place, and then you can move on to the others. The others will generally hop on the train only after everybody's already doing it anyway. We like to talk about just try it on a cycle of one office, one person, one subject. I wonder if I can actually, ask a person about their socioeconomic status. Can I collect that information? Can I do it? Can it be done? When you get used to doing this PDSA cycle really becomes your language for quality improvement. You say, I'm just going to test it. Like today we're going to test something in a moment that I've never done before. And you do it side by side with what's existing. In other words, Joe and I are the team with that one provider that's doing our little quality project. Everybody else is doing their immunizations the way they normally do them. We're just doing a little test. When we feel pretty confident that that works very well, then we're going to spread it, but it's always doing side by side with what's already there. And once you're pretty convinced that what it is that you're doing works fairly well on days, because what we're doing right now is in days, are the MAs still going to be able to collect that same information on Wednesday when the clinic's open until 7:30? Are they going to be able to do it on Saturday when we have fewer providers and fewer MAs there? So you try it with the kind of generic situation, and when you're pretty sure that works, then you try to change across different shifts and conditions just to see what modifications you might make in the work. So we're going to do a test today. And I would ask you to tell me what it is. Anybody have a test you can think of you could do this afternoon? Could be your personal life, could be like I'm going to get out there in that traffic with the viaduct closed, and I'm going to try to get home a different way than I did before. I mean, we all do this all the time. It's just getting it into your mind that this is a structured way to do quality improvement and taking the time to go through the steps. So now you have your model for improvement, which are just 3 questions. Always remembering what you're trying to accomplish. Having a nice set of metrics that aren't intimidating, that you can actually collect and post easily without letting technology scare you. And having some changes that you believe are actually going to result in the improvement. And using then the plan, do, study, act cycle so that you can change things fairly quickly with very low risk, learn just enough to help you think you're on your way in the way you're hoping you're going to be, and you can make things bigger as you become more convinced that things are going well. We are going to practice now. This is my PDSA cycle. So did you all get a kit of these threaded rod with 4 wing nuts on it? Oh, I should have taken this apart. Okay, so hopefully your wing nuts are off of the threaded rod. That's the first step. So this is going to take me forever. I should have done this before. Okay, who said no? Okay, it's just taking me a second. Yeah, okay, so we'll wait and see if that appears. Again, this is a Plan, Do, Study, Act test, so I don't want to, so in Skagit you have them, right? I saw the baggie. Do you have more than one set? Okay, this is a team activity, so I can only see, what's that, 7 people? So 8? Do you want to make 2 teams of 4? It's team activity, it's QI. 2 teams of 4. All right, make sure all of the wing nuts are off. Sorry about that. Okay, 2 teams of 4. Everybody knows who teams you're on, right? Okay. Here's the deal. The threaded rod. I call it the nut and bolt game, but technically it's not a bolt. My husband is a shop teacher, and he informs me it is a threaded rod because it doesn't have the little screwdriver end on it. This threaded rod represents your clinic. The wing nuts are your patients. The object of our work, this is our aim statement, is we're going to get all 4 of the patients. They have to start out outside the clinic in the parking lot, and they need to go through our whole clinic as quickly and safely as possible because, boy, we want to see 35 patients a day, and we don't want anybody falling, so we're going to be fast and we're going to be safe at getting this done. This is a team activity. Well, I'm not going to show them how to do anything, but I'm not really going to show you how to do it. But it is a team. It's a team sport because you're going to do it your own way. You're in your own clinic with your own constraints. But we're going to get all of the patients starting off and then coming off, starting off and then ending up back off. And we don't want anybody falling, and we want to go fast. So what do we know about how fast and how safe your process is in your clinic? Do you know anything about it? Okay, they're being very quiet. Okay. Not sure if you're saying anything, but we don't know how well this system works, right? You've never seen this system until like 1 minute ago, so we don't know anything about it. So this is the first thing you need to do with your quality improvement project is you have to get some baseline data, right? You're not sure how much of a problem you have until you do it first. So we're going to do one round of this as our baseline data. I, again, have not done this, and we have a team here that's going to do it too. And so everyone has to touch it. This is a team thing. We can't just have the manager doing the work and everybody watching because that's not quality improvement. So everyone has to touch it, and we're going to go for it, and we're going to collect the data. I probably won't be able to hear if your nuts and bolts or whatever fall on the floor, so you'll have to tell me. And what I'm going to do is, I need to write down the times. Okay. Oh, they're practicing. Okay, is everybody practicing? Take them all back off again because we're going to start. What I'm going to do is I'm going to time you. When all of the nuts are off of there, raise your hand and I will capture the time. Take them all off. Practicers. The healthcare people are so competitive. It's so true. Okay, so I'm just going to get my my little stopwatch going, and when all of them are back off, please raise your hand and I'll call out the time and we'll just capture it on this sticky note here. Okay, you ready? Uh-oh, all the way off. All the way off to start.
Sorry.
The faculty. Okay. Okay, ready, set, start, go. Put your hand up when you're done. One man down. Okay, do we have folks working on it over there?
Are we raising hands when we're done?
Yes, when you've got them all off. Okay, there's one. That's at 54 seconds.
4.
And,
Go record. 4.
yep. Okay, 108. And I think there's one team still working. Other people couldn't find their kit. Okay, are you passing it around at the other group, or are we still going?
How's it going? Are you guys still working?
I think there's a team still working. Is the second team done? I don't think so. Okay, is everyone done? Okay, all right, one. Okay, all right. I'm not sure exactly how long that took because I didn't see a hand go up. So, all right, it looks like we wrote down a couple of times, and one was just under a minute, it was about 54 seconds. One was a little over, 108. The other one I think was about a minute and a half. The last one, I couldn't see the person on the end. Apologize for that. So, that doesn't mean good, bad, does it? It's just the way your team worked. That's your baseline. That's all you have. You can't make any judgments about it. So now you're going to do your plan to study act cycle. In your team, plan what might have made that faster. What do you think might make this faster or safer in your team?
Can you unmute yourself so we can actually hear you? Give the controls for your webcam.
Yeah, we don't have the ability to hear you, unfortunately.
Before there was a remote, somebody unmuted this gadget so you can hear us? Hear you?
They might have put it down up here toward where the camera is. But, so why don't you take...
Can you guys hear us?
Yes.
Now we can hear you. Okay.
Yay, excellent. So why don't we take, you need 30 seconds to think of what you're going to change about your process. Don't start them all ahead of time because they all have to start off. That's one of the rules. So everybody take 30 seconds, make a plan, and then I'm going to say, Mark, get set, go again. Plan something you're going to change.
And I see Puyallup, Falmouth, FedEx, and Globe. Yay!
Okay.
You can still join in. You have threaded rods. Yay!
Yeah. So you're just going to be getting your the wing nuts off, starting totally off and getting them through the system and back off again. And right now you're thinking of a way to make it faster. Okay, everybody take all of them off again. Okay, so does everybody have a test that you're thinking of doing? Let's make sure all of those lovely nuts are off of the rod. And we're going to start our test of change. Are you ready? Okay, starting your test of change. Set. Go. Start again. Put your hand up when you're done. I might need to zoom out so you can see if they raise their hand. Well, because I feel like I'm not seeing the person raise their hand because they're off. Like, I don't know what that group is doing. Yeah. No. Oh, that's true. It's fine. Okay, 48 seconds. Okay, 52. Okay, 57. Okay. Okay, these guys.
Totally not beating each other.
103. You took time off. Okay, is the last group done? But I see a group there with, okay, got it, 111. Very good. Okay, so I didn't catch all the data from the last time, but we do have quite a bit more kind of standardization in the times now, because ranging, we had a 52, 57, 48, 52, 57, and 111. Somebody tell me, and I think Skagit's unmuted now, is that right? Is that the group that was unmuted?
Yep.
Can you tell? Yeah, give me an example of what you tried to make it better.
We oriented one of the threaded, sorry, what was that?
Threaded rod.
Threaded rod, thank you. Oriented vertically to use gravity, and then had multiple leads on top of it to drive it down faster.
Okay. Anybody else? What else did you try?
Press one started the nut, another one kept spinning, the last one spin it while we started another one, and we kept going. So there's 3 people spinning at once.
So you kind of had, you changed kind of the roles and responsibilities. The other folks kind of changed the way the system worked. How about our team here? What did you try?
One of us loaded, we were always, one of us was spinning or loading.
Okay, so they kind of did that same kind of thing. We're spinning and loading at the same time. How about the other team at Skagit? Anything you tried? You don't know exactly what? Okay, we're going to do one more test of change now, because everybody's getting better. So think of one more test. We're going to give you another 30 seconds to think of something else, and we'll run it again. Teams plan something. What do you think is going to make it better? What did you just hear suggestions about? Our new test here is to get more people. That is a very common solution in healthcare. We just need more people. Exactly.
There it is.
All right. Because we're a little low on time, we're going to go ahead and just run our test now, okay? You had your time to plan it. Are you ready? Get set. Start. Okay, 46. Okay, 53, 54. Woo, 55, look at us go. All right, is that the whole group of us? I think so. So look at what happened. So it may just be because of practice, but the times are much closer together, 46, 53, 54, 55. We don't have time to do a third round, but you guys have the equipment, so you can certainly do it. The whole, so the idea of this practice game is to teach several concepts. One is that when you have a system, you don't know its performance until you get a baseline. You know, you can kind of know benchmarks if there are any. I don't have any benchmarks for this, although I kind of do. So you have to get a baseline. You're generally comparing yourself only to yourself and not to others, but you will see as the teams start kind of watching each other and copying what each other do, that performance tends to get narrower, the gaps get narrower between the high and the low. I would be asking you, and I'll ask you right now, did anybody adopt a change that you heard somebody else say or were watching? Like you may have seen something you definitely didn't want to try, but it's kind of an example that within a collaborative group that's all working at the same thing, that you can learn a lot from each other. And that if a lot of people are doing cycles together, you can be saying, gee, what did you try? And I can try that in my setting in just one little test that's not going to hurt anybody and just see if it works. You can learn really fast and you can learn from others. Another thing you might find in this demonstration is that some people would say, well, we turned it sideways and we had Susie hold it and we had Bob because he seemed to be the fastest. And then I would say, how do you know which one made the improvement? Because you wouldn't know. You tested 3 things at the same time. So if you're really after causality, you keep your tests super small and try and test just one change at a time. So that's a thing that this game can teach. And the other one, which we didn't unfortunately have time to do a lot of iterations, is a lot of people make up rules in their head that I didn't say. They'll say, oh, I thought you said blah, blah. Like, no, I didn't. All I said was that everybody has to touch it and the patients have to get on and off the system. Everything else that you built in your head is a construct. And we do that a lot in healthcare. I thought I couldn't. I thought it had to be. A lot of times that's not true. So that's our little demo of that. And I'll zip through my last little slide. So the idea is just to keep doing these tests. You can do tests literally several times a day if you want to on the thing that you're working on, if you get the opportunity to do it. And everybody's going to learn from things that we thought, gee, I think this is going to make it better, to really finding out that that did result in improvement. There are resources that will allow you to document your aim statement and track your PDSA cycles. I can send the team the link to where they can find this stuff if you like to be official about it. And the one last little deal, and I know I'm a couple minutes over, is to say this in the end is all about change management. And change for some people is beautiful and awesome, like Walden Pond, and for other people it's horrible. And you can't necessarily change that about yourself. If you're a change hater, you're probably always a change hater. If you like it, you like it. But we're going through change. And this is another model on the theory that all models are wrong, but some are